And so I think we all know you are not alone. Often people feel isolated. I've had patients come to me after 35 years without having a diagnosis and really suffering. And this was really a good population-based study that you're seeing. And the prevalence actually, or how common CVS is about 2%, which means 2 in 100. And if you kind of fill this a little bit more, maybe there are 50 people here, so one of you, or if you just went to the general population, have CVS. So it's common, you're not alone. And it's very unfortunate. This is actually old data. And this is kind of the story as it unfolded in the US. And this was a study we did in 2010, and that was a story that I often heard. And if you look at this, the total number of ED visits, or a median, or kind of like an average, if you will, was about 15 for adults. And I have seen patients personally who have told me that they've been to the ED 200 times. And I think as a medical community, I felt, or I still feel, we have failed them. If somebody has to come to an ER 200 times and, going around in circles, then I think that's very, very wrong. The diagnosis was not made, at least in adults, most of the time, and even in children. Even though it was thought to be a pediatric disorder, we now know that it can actually affect people of all ages. It can start at age 2. And I have patients who are even 80 years of age who have CVS. So really, it has a significant impact. This is again US data. We used, some market claims and insurance claims database. And if you look, the column to the left are all CVS patients. To the column to the right are non-CVS patients, and we match them for age and what we call comorbid conditions. And on average, they cost about $60,000 a year compared to non-CVS patients. So it was more expensive. Really, this data is important, I think, to understand why healthcare systems need to address this. And it's great that, I have a colleague and a friend in Dr. Corsetti, who's really taking the lead in the UK with this. And as you can see here, the purple bar, most of it is driven by inpatient care because we don't have we have some therapies, but again, we need to do more. And what about short-term absenteeism? I have a lot of patients who lose work and they actually lose their jobs even. And you can see here that on average, they lost about 21 days, at work, which is about 3 weeks. Again, this is what is captured, and I can tell you that there are a lot of people who really need to take off work a lot. And this, again, results in out-of-pocket costs and wages lost, and so on. And so unfortunately, a lot of people kind of dismiss CVS saying, oh, well, they just vomit, but it's not just that. People actually lose their jobs. They're not able to keep a job because it's unreliable. It's unpredictable, as you know, and it comes out of the blue, and then you have to call your employer and tell them that you can't be there for several days. There's a delay in higher education. There are a lot of patients I have who've unfortunately had to either drop out of school and so on and so forth. There are a lot of medical bills that are incurred, at least in the US. Fortunately, maybe here you have a better healthcare system. And then finally, there's a societal impact, and it's very sad. I've seen people who come to divorce because it's just something that other people don't understand, and having a spouse or a partner who's constantly throwing up really leads to significant disruption of the family unit. And how do we diagnose this? I think the diagnosis, like Maura would say, is in the history, and you guys all know that. Now, we don't have blood tests or biomarkers, which means that I can't send you for a blood test or an X-ray test to quote rule in or diagnose you, but the history is very classic. So you need to have at least 3 episodes of nausea and vomiting, at least in adults. In children, it's about 5. And they typically last for a week, but I will say that we have a study that we're actually just submitted showing that there's a huge variation in presentation, but it can vary from a few hours to many days, even 10 days or even more. And so, everybody is a little different. Most people go back to normal or baseline, but everybody's quote normal is different. So there are patients who will often have abdominal pain, chronic nausea, maybe some kind of low-grade vomiting, particularly if you suffer from CVS for a very long period of time. And so you can have symptoms in between episodes which are mild. And obviously you need to have this for at least a year. So these are the diagnostic criteria that doctors use when a CVS patient comes to us. And these are the phases of CVS. Everybody knows it. You know, when you're well, everything's okay. And then you have the prodromal phase, and the prodromal phase is important. Now, during a prodromal phase, similar to a migraine headache, people can have, just a sense of not feeling right. They can have abdominal pain, nausea. They can feel hot, they can feel cold, and some people have this impending sense of doom that something really bad is going to happen. And why is that important to recognize? Why am I telling you that today? Because there are steps that you can take. There's a toolbox or a toolkit that you can use to try and prevent a progression of that episode to the emetic phase. So you can take your medications, what we call abortive or rescue medications during that phase, and hopefully prevent progression to what we call the emetic phase. When somebody is in an emetic phase or they're vomiting, it's very difficult to really you can, give people medications, but often, as you know, they land up in either the emergency room or the hospital or infusion clinics and so on. And it's important, even though we call it a vomiting disorder, it's not that simple. So you have nausea, you have vomiting. People can have abdominal pain. About 80 to 90% of patients can have abdominal pain in different series. And people feel hot, they feel cold, they can even have diarrhea. It's kind of coming out, unfortunately, both ways. And, some people can also have a headache, but not all. So there's really a lot. Some people, you have sensitivity to light and sound, and you just want to be curled up in a dark room and have nobody disturb you. Now I'm going to kind of focus a little bit on management of CVS and what we have. So I get this question asked a lot. I can't say anything about the former one, but the latter we'll try. So it seems like we're in an eternal cycle. And so this was the guidelines that we published, and so what happened is as things go by, it was frustrating because even in the US, our story goes back 15 years. There were so many people, physicians who didn't know what to do, didn't know how to do it. And we said, okay, it's time for guidelines because, there are only so many people you can speak to. And so with the CVSA in the USA and also the ANMS, or the American Neurogastroenterology and Motility Society, and it was actually published in Neurogastroenterology and Motility, where Maura is an editor now. And so we came up with the guidelines, and we looked at all the data. We actually culled all the data. And then we said, okay, this is our general approach. So you look for comorbidities. First, you make a diagnosis, and then you look for comorbidities. Do you have anxiety, depression, autonomic dysfunction, anything else that's going on? And then you assess severity. Now, we don't have validated tools, and hopefully in the future we can look into this. But we divide CVS into mild, moderate, or severe. And so this is sort of an arbitrary classification, but if you have, say, moderate to severe CVS, typically these patients have, the case that Mohsen presented has severe CVS because this person was having monthly episodes. So if you have multiple episodes, 4 or more a year, long episodes, more than 2 days in duration, or if you have to go to the ER or the hospital and it's really disrupting your activities of daily living, then we consider that you have moderate to severe CVS. And for those patients, we recommend, or at least we will offer, prophylactic therapy or preventive therapy, because you really want to try and prevent the episodes from happening instead of playing catch up all the time. Certainly there's something called rescue therapy or abortive therapy, and we offer abortive therapy to all patients because I think you need a toolbox. I think what is very stressful is it's unpredictable, and 2, if you feel like you don't have any control over it, then that becomes even more stressful because you don't know when it's coming, and if it's coming, you don't know what to do. So we want to let you know and engage you so that you know what to do. And so if you look at abortive therapy, I think this is the cornerstone, and there are a few studies to show efficacy. There's something called triptans, which have been used in migraine headaches for a very long time, something called sumatriptan, and typically what we recommend is the intranasal route, because as you know, if you're vomiting, nothing's going to stay in your stomach, you're just going to throw it out, or it's just going to sit there and not get absorbed. So we try and avoid oral medications at all costs. And so really intranasally, 20 milligrams, and then a neurologist taught me this, so there's a technique called the lean forward technique. So don't lean back. If you lean back, the sumatriptan will go to the back of your throat. It tastes bitter and nasty. So lean forward, take a slow deep breath, and take one 20 milligrams intranasal spray, and then you just take deep breaths and wait. You can repeat it in 2 hours if need be. Excuse me. It always comes in twos. So you can repeat it in 2 hours if necessary. And then there are things like ondansetron or antiemetics. Now, all patients with CVS don't always respond to ondansetron, but that's certainly something we do. I didn't put it here, but I also recommend things like Benadryl or diphenhydramine if you can get yourself to go to sleep, which is difficult during an episode. That will also be very helpful. And then there's a newer medication called aprepitant that I will touch on. And what about prophylactic medications? So these are your prophylactic medications. Basically, you have first-line treatment and then second-line treatment. And first-line treatment is what we call neuromodulators. So the center for vomiting is in your brain, and the network for nausea is also in your brain. So your brain is like a supercomputer, and it's kind of sending bad signals for multiple reasons. And so, what we try to do is to modulate or kind of change the way that system sort of talks to each other, the brain-gut communication, if you will. And so there are two medications called amitriptyline and nortriptyline. They're kind of cousins of each other. There's something called topiramate. And then we have newer, or at least not newer class of medications called NK1 receptor antagonists, again the aprepitant and the fosaprepitant. And then you have something called mitochondrial supplements. Now, if you look at the efficacy of amitriptyline, and some of you may be on amitriptyline, the case that Mohsen presented, I think, was on 20 milligrams of amitriptyline. And so if you can see here and you follow that at baseline, the frequency of CVS episodes was about 17, and this dropped to 3 after 2 years, and then the duration of CVS episodes was also cut in half from about 7 to 3, and then the number of ED visits and hospitalizations also went down significantly from 15 to 3 with amitriptyline. So, it works. And this was another study that we did. This was again a retrospective study, and if you look at it, most people had what we call a complete response, which we defined as at least an 80%, they felt 80% better, or a reduction in symptoms. And so about 60%, felt great. And then there was about another 30% who definitely improved, and there was only about 14 or 15% who didn't improve, and those people tended to be those who are on chronic like opioids, pain medications, or very heavy cannabis use, and so on. And the mechanism of action is independent of its antidepressant effects. So, you can Google everything now, and if Dr. Google tells you it's an antidepressant, it's not because we think, you're crazy or anything like that, and don't feel like that, because it actually, causes what we call neurogenesis. So it can make new communications in the brain. And you can actually change the way you think, no matter how it is. There's something called neuroplasticity, which actually is there even as we age. And so that's what we try to do when we give you amitriptyline or nortriptyline. And the dosage is typically we start low, and then we go up. And Mauda had presented some data, and it's possible that the doses are a little different in Great Britain as opposed to the US. We need higher doses. In the US, we do recommend checking an EKG at baseline, because we look at something called the QT interval. And so this is what we do, and this is another study we did, and it's just important to remember. This is a little bit of pharmacology, but it might be useful for you to understand. So amitriptyline is basically converted in the body to nortriptyline. And then there are two enzymes. We have a lot of enzymes that break down, drugs or whatever else we ingest. And so there's something called CYP2C19 and CYP2D6. And then if you look at the pie charts on the right-hand side, you can see that many people are what we call normal metabolizers. So normal means extensive. So that's the purple area. But then if you look at the green area and you look to the right-hand side most corner, you'll find a small sliver, okay, about 2% of people, at least in the US, in this patient cohort, were what we call ultra-rapid metabolizers. So I can give you 100 milligrams of amitriptyline and you're going to chew it up because you have that particular gene, and that's really going to chew up the drug. And I have patients who've had levels of 0, and they're compliant, but then it's not enough for them. And so, this is something that needs to be borne in mind. And some people may need more, some people need less. So, it's like one size doesn't fit all in medicine, as we all know. And so that's also important to keep in mind. And side effects, unfortunately, side effects do occur in 25%. I tell my patients, you got to push through the side effects first. It's like going to the gym. You got to kind of put in the hard work and sweat it out before you get those six-pack abs. And so you really do need to wait for that 8 to 12 weeks before you start seeing any effect. Like if I start a person on medication now, I'm going to tell them you got to wait till fall, and then let's see. Unfortunately, that's what we have right now. It does cause some daytime sedation, so we recommend that people take it or patients take it at night or bedtime so that it actually promotes sleep, and people say, hey, I sleep great. One of the problems is weight gain, and of course, for women, it's harder for us to lose weight, and so that's a problem. I've had patients sometimes. I walked into clinic one day, and this patient was literally sobbing, and I said, oh gosh, the medicine didn't work. And then she said, look at me. I said, what? And then she said, I've put on like 15 pounds. And then she had stopped vomiting, but that was a problem for her. And so we had to make some changes, and sometimes we'll switch to nortriptyline. Nortriptyline has a little less better side effect profile than amitriptyline, but we do like to start with amitriptyline because most of the studies have been done with amitriptyline, and even though they're so closely related, they seem somehow to maybe work better. Now, again, topiramate. So topiramate is another medication that's used, and again, as you can see, before and after topiramate, the number of episodes was cut down from 18 to 6. Number of ED visits, again, my patients have severe CVS, so that's why you're seeing higher numbers here. And number of ED visits went from 4 to 2. Number of hospitalizations, again, went down by half. So, it does seem to work. Unfortunately, there are some side effects, and really some people just don't like it. They call what we call cognitive dysfunction, and they feel they just don't feel great. They don't feel very sharp. And that can be a problem, particularly in pediatrics. I can see some children here with their parents, and so my pediatric colleagues don't like it very much. For those reasons. And this is a new drug, and I'm actually a big fan of it. It's called aprepitant. It was actually studied in chemotherapy-induced nausea and vomiting, and it's used both for prophylaxis, for prevention, and abortive therapy. So in terms of prevention, typically we would give it 3 times a week or sometimes even daily if you have very severe CVS. As abortive therapy, if like during the prodrome, or some people say it occurs during a menstrual cycle, I'll have patients take it when it's like if your cycle is going to start tomorrow, I'll say start taking it today and then try and see how it works. Insurance is a problem, as you can see, but we do have patient prescription assistance programs, and so it is manufactured by Merck, and they do really provide it for free if you sort of meet their criteria, and about 71%, so that's kind of pretty good, of people who had refractory CVS, so they had actually failed other medications, and I tried them on aprepitant, and so that really seemed to really work in these patients. I can tell you that For some people, it's been like a miracle. And I've had patients who've just been so, their lives were gone, basically. There was nothing to lose. And, we started them in Emend, and it was like a miracle drug. So if it works, it works. The side effect profile is great. It does reduce the efficacy of oral contraceptive pills a little bit, and that's all you need to, tell your patients. Not that I have a bunch of people who became pregnant after using it. Cost is an issue. So, hopefully, I don't know, in your system, you might be able to get it. There are a lot of comorbidities, it's like this, unfortunately, like this octopus, and, it's very rare that I see a CVS patient come in and it's like, oh, you only have CVS, because there are a lot of comorbidities. A lot of patients with CVS have anxiety or depression, and we don't know if it's the chicken or the egg. Obviously, the CVS is making the anxiety and depression worse, and the anxiety and depression make the CVS worse. And so we really have to treat everything. People can have what we call autonomic dysfunction, and that's a different thing, where your autonomic nerves are not working very well, and so you might also need lifestyle modification and maybe some medical therapy if need be for that. People may have migraine headaches, and so you really need to treat all of those conditions. And stress is a huge trigger for CVS episode. At least in our series, about 70 to 85% of episodes are triggered by stress, and they don't always have to be negative. When we think of stress, we always kind of have a negative connotation to it. But I have people who birthdays, vacations, family reunions. Now, depending on your family, it can be good or bad. But those can also be very stressful, maybe in a good way. And so that can trigger a CVS episode. And so there are some things that can actually, help this, whether you need to go to a counselor or, whatever your deal is. And this, we actually did a study, an open label trial. And we had patients do what is called heartfulness meditation, which is actually free for 6 weeks via an app, because we did a previous study with actual instructors, but it was very difficult to schedule. So this was self-paced, it was easily accessible. And essentially, we looked at various psychological outcomes, and we found actually there was a significant reduction in anxiety. In anxiety scores, their mood improved, their sleep improved, they had an increase in quality of life, improved quality of life. And there's something called endocannabinoids that I'll touch on, and it was able to what we call augment endocannabinoids. So endocannabinoids are like happy neurotransmitters in our body. And so these are also things that I think you should think of, because we tend to we use what is called a biopsychosocial model of care, and health is something which is different, it's holistic, right? Just because somebody stops vomiting doesn't mean that you're feeling great. You could have nausea, you could have anxiety, so you want to feel better overall. And so I think we need to think of it that way. And so, like I said, you treat the other disorders. This is something actually that's done in children. We are yet to start a study in adults. It's something called the IB-STIM in the US. It's FDA approved for IBS. And this was actually a study with my pediatric colleagues in Wisconsin. It was a 6-week trial. It's actually non-invasive, and basically it's just placed in the ear. Every week you take it off. You wear it for 5 days, you take it off for 2 days, and it, you just kind of cover your ear, and it kind of looks okay. And so this is something that actually stimulates branches of the vagus nerve, and the vagus nerve is actually very important in stress and nausea and vomiting. And so what these were all the outcomes that we looked at: so abdominal pain, anxiety, sleep quality, and also quality of life. And then if you look at the results, there was actually improvement in abdominal pain over 6 weeks. There was an improvement in anxiety as well over 6 weeks, and that seemed to be sustained a little bit at 3-month follow-up. And then finally, there was also an improvement in sleep quality. Again, this is an open label trial. There have been other randomized control trials looking at, say, functional abdominal pain in children. Most of the data is in children. We started a study, but then COVID hit, and then we shut it down in adults, so we don't have data in adults. And so there is obviously a company that produces these, devices. And so this is sort of available, and that is also an option. Now, switching a little bit to an ED protocol, I think, so your preventive medications are going on, you have your abortive medications, but, sometimes they fail. And what do you do? So I think it's very important, and I know that Maura also does that. Anybody who comes to my clinic, and that's what we're trying to teach other people to do, is that if you see a CVS specialist, they'll typically give you an ED protocol. So one is, at least you have a validated disorder. It's been diagnosed by somebody who's a gastroenterologist or who's an expert, and they will customize this protocol. So what do you have? That you have X, so X patient has cyclic vomiting syndrome, and you give them IV fluids, you give them antiemetics, and then you give them some sedation, and so this is how you manage them in the emergency department. Obviously, the emergency department is very busy, so I try to keep my patients out of the emergency department. We have infusion clinics, at least in the US, and now actually in Columbus, we have something called Dispatch Health. Well, they'll dispatch somebody to your house to give you IV fluids. And, there's some of my patients, not that I recommend this, they have these hangover clinics where they give you IV fluids. And so if they're really, really, really kind of stuck, they say, well, I went to this hangover clinic and they gave me IV fluids. Again, I don't recommend that because that's not regulated. But anyways, these are things that I think it's important to have. Share it with your physicians, share it with your local ED when you're well. Maybe go to the nurse manager and say, look, people are, not very communicative or easy to understand when you're in a flare, because you're really vomiting and it's very difficult to have that conversation. So it might be easier when they see you and they see that, hey, this is like, you're just normal like everybody else. And so that might also, kind of help. In terms of adults versus children, again, I'm not a pediatrician, but I'm married to a pediatric gastroenterologist, and I diagnosed my first case of CVS with his help. And so they call me an honorary pediatric person. But, but anyways, we use the same medications in children. My pediatric colleagues also use the same medications. One of the things that's used often in children is cyproheptadine, and that's typically under age 5. I have used it in some adults, and the problem with that is like your weight just goes up like crazy. Again, neuromodulation there's more data in pediatrics really with this disorder. And then there's this new thing that came up, and I don't recommend everybody go off and do whole exome sequencing. Please don't do that. But anyways, there's something called JDVS, and the CVSA, Kathleen, Robin knows Kathleen, and her daughter had actually whole exome sequencing, though I kind of said, hey, be careful. But there was this thing in Holland. There's a person called Jan de Vries, and there's this particular gene mutation that they discovered, and they found there's, how many ever, maybe 50 families or so on and so forth. And having looked at these patients, they do have this particular sort of clinical constellation, if you will, with the JDVS or the Jan de Vries syndrome, where it's basically a mutation in chromosome 17. So there is a specific mutation, and it makes the protein small. And so these are the clinical features, and actually the one at the bottom is Molly. She's, Robin's counterpart's daughter, who's had CVS for 40 years. And there's this kid. So they have these faces, and they're kind of actually happy people. They love people. They're people loving. And they have these unique facial features. They have short, small hands. And they appear to have even a lot of, vomiting. And so that's something, to bear in mind. And they do have some neurodevelopmental delays. Molly she started vomiting at age 2. She's okay now, and her mother basically kind of ran the CVSA for 35 years. She's just, she's like an angel. She's an amazing person, and she did step away from that role, but she still is very active. And you might ask what happens to us if I'm going over time or anything. Maura, tell me. Sorry, I put in a few more slides. And so as far as the natural history in children goes, There's some data that, if you get it as a child, about 70 to 80% will outgrow CVS and develop migraine headaches. So that's good news, right? You stop vomiting, you just have to hit that magic age and you get better. This is another study on the right by somebody called Claudio Romano, which, kind of looks okay as well. And so basically, if you look at this pie chart, about 50%, just stopped vomiting. And then there was about 7% who stopped vomiting, but they started having other GI symptoms. And then there were, again, about half of them, or less than half, about 40% or so, continued to have some vomiting episodes if you had CVS as a child. And, out of that, so again, some of them, about a quarter, had other symptoms. So, kind of split up that way. So, I do have to talk about cannabis. I know it's not such a big issue in the UK, but I worry, that sometimes these bad habits that we have in the US kind of trickle over. And so there's something called cannabinoids. Cannabinoids are really these substances that bind to what we call cannabinoid receptors. We have cannabinoid receptors that are densely distributed everywhere in the brain and in the gut and so on. We have phytocannabinoids, that's kind of weed or marijuana, because phyto means plant, and then you have endocannabinoids. So we actually produce these neurotransmitters in our body. There's a basal tone, and then we also produce them on demand when we're stressed. And then we have synthetic cannabinoids that people make in the laboratory. And so why are they important, at least in the US? Here I know it's still not legal except for medicinal use. But if you look at it, this is the prevalence data. So the prevalence of use has gone up in all ages, 18 to 25, 25 and onwards. As you can see, the chart is just, going up and up and up, and over the last 20 years. And this is how people perceive it. In the past, about half the population perceived it as risky, and now almost nobody thinks it's risky. So, everybody's basically using it. And these are the trends in potency. I hate to say this, but I'm sure Robin didn't smoke weed, but anyways, in his childhood, when they used weed, it was maybe like 3 or 4% of what we call THC, which gives you the high. But now you can get weed which is 65% potent, so it'll knock a horse down. And so, what you get and what people are selling in the US is crazy. And it's a $1 billion industry. And so, everybody's agreed on that, legalizing weed and selling it, just like the tobacco industry. So you really have to be careful. And if you, are using it, what kind of weed are you using? How are you using it? Is it too potent? Are you using it daily? And so on and so forth. Because the risk of actually dependence on weed increases as you use more and as you use more potent products. And it also has what we call a biphasic effect. So if you give, say, weed to a dog that's vomiting, it'll stop. Now, the reason why nausea vomiting disorders are so hard to research is rats and mice don't vomit, and most of our animal models are rats and mice because they're cheap and they're easy, and you can kind of, and so nobody wants to do experiments on dogs. But be as it may, weed, when you use a lot of it and you use high potency, it actually has the opposite effect. And instead of making people feel relaxed, it can actually induce anxiety. It actually even, there's data to show that in children, particularly with, growing brains, there's reduction in brain volumes and so on. So, it's problematic, and it's still being legalized in the US, as you can see. And then you all might have heard about cannabinoid hyperemesis syndrome, and it's basically similar to CVS except that it occurs after prolonged heavy cannabis use. Approximately about 5 to 10 years of use, and like I said, you keep using it, you might develop a problem, and we think it's a subset of CVS because if you're genetically predisposed to CVS and you throw marijuana on top, then you're really kind of getting into vomiting symptoms. And this was a study that they did, and actually it was first legalized in Colorado and California. So people started traveling to Colorado in the US. There was like marijuana tourism, and then they found that the ED was actually inundated with these tourists who really were taking all these cannabis products, and so the number of ED visits due to nausea and vomiting and cannabis use went up in Colorado. And it was the next data that I'm showing is very scary. Like pandemic and post-pandemic, they found that there was increased incidence in overdose due to cannabis in children 0 to 10 years of age. There are like kind of cookies and brownies laced with marijuana. So children, adults used it and they just let it lie around, and so children were actually ingesting it by mistake. And they would just land up in the ER and they had to be resuscitated. And I know somebody whose name I can't disclose, but she saw cookies lying around, and her son had brought it in during Thanksgiving, and she had to be taken in by her daughter to the ER because she almost stopped breathing. She just didn't know that. She took one cookie and then 2 cookies, and then you know how it is. So it's kind of a bit scary. And so at least, CHS is supposed to occur in young males because they tend to use more marijuana and heavy use. There's something called hot water bathing pattern. Now, it's not what we call diagnostic of quote CHS, but people who use marijuana tend to actually have these hot showers or baths. And even people with CVS who don't use marijuana at all, 50% of them, and I don't know how many of you kind of exhibit that behavior. It's just some sort of self-learned behavior where you go to the bathroom and people have 20 hot showers a day, or they will just sit in the, just sit in the bath in hot water till it actually runs out. I've had patients who checked into hotels because, you get a continuous supply of hot water in hotels. And so this is what you see, and this is something which is very peculiar to CVS and, CHS, if you will, but like I said, it's not what we call diagnostic of pathognomonic of CHS. And these were some, cannabis users. We looked at these patients in my clinic, and, most patients, about 60% said they never used it. Usually it's about 35 to 40%, and there's about 22% of patients, so 1 in 5, did use it more than 4 times a week. But if you looked at all of them, they said it actually improved all of their symptoms. So they said it improved nausea and vomiting and abdominal pain and reduced, hospitalizations and ED visits and so on. And most of them abstained because I do tell them to cut down when they come and see me. And there was only 1 person actually who abstained and had complete resolution of symptoms. So I do have patients who get better when they stop the cannabis use, but they don't get all better. So I think it makes CVS worse. I don't know if it's necessarily causative for that. And so we did this systematic review, and unfortunately there's a lot of literature on cannabis. I don't want to get into the nitty-gritty and the details like I would maybe with my medical colleagues here. But be as it may, the literature doesn't really, it lacks detail for us to really say, hey, this causes this. I mean, this was associated with this, but it doesn't cause it. And a lot of people say, hey, marijuana is an antiemetic, and we have data for that, so that's why we're using it. So I think we need more studies, and hopefully we'll get more funding to do that. And so in terms of hyperemesis of vomiting, we do have some data. People can have a genetic predisposition to it. I didn't get into it a lot because I know we were tight on time here. There's something possibly an endocannabinoid deficiency. So these endocannabinoids are these wonderful neurotransmitters that we have, and there is some evidence to suggest that patients with CVS might have genetic, sort of defects or mutations in certain genes that code for this system. And, also the potency of cannabis products. So be aware, just like tobacco, everybody sold, sold tobacco, and it was 40 years before, people said, oh, okay, well, maybe you're right, even though they knew that. So you just need to be a little careful. So I will hand it over to Maura, and then maybe we'll take questions later. Thank you.